So good morning. So yes, I am Clémence Basse, and thank you for the introduction. I am working in Institut Curie in France, and I'm happy to present the recent updates for clinical trials and emerging treatments concerning immunotherapies. But first, I wanted to remind you the context about immunotherapies because immunotherapies regroup diverse treatments and with the same purpose, that is to enhance the immune response against cancer cells. So there exist different immunotherapies, and this figure, you can see some immunotherapies modified the T cells. They are the CAR T cells. We have the TCR T therapies. There exist also immunotherapies that are meant to boost immunity with cytokines activators or natural killer cell therapies or immune infiltrating lymphocyte therapy. However, the two main immunotherapies that have been tested in thymic epithelial tumors so far are mainly immune checkpoint inhibitors, and that is the treatment I will talk about mostly. Immune checkpoint inhibitors, antibodies against either the PD-L1 receptor on tumoral cells, here on the right, or they can be against the PD-1 receptor on cytotoxic CD8 T cells. The purpose of immune checkpoint inhibitors, they can also target CTLA4, but the purpose is to stop the inhibition signal that tumoral cells send to T cells. And you can see here on the right that immune checkpoint inhibitors allow cytotoxic CD8 T cells to attack and to destroy cancer cells. I wanted to say that there also exists tumor vaccine as immunotherapy, which require an epitope from tumoral cells. And some early phase clinical trials were developed in thymic epithelial tumors without very conclusive results so far. But what is the rationale to use immune checkpoint inhibitors in thymic epithelial tumors? Immune checkpoint inhibitors are used in many other cancers. And we know that there exist some biomarkers of response to immune checkpoint inhibitors. The first most known biomarker of response is the level of PD-L1 expression on tumoral cells. And this is detected by immunohistochemistry. And when the PD-L1 expression is high, there is a better chance to have a better response to immune checkpoint inhibitors. And what do we know is that in thymic epithelial tumors, the PD-L1 expression is reported to be high, between 30 to 100% in different cohorts. But however, in the normal thymus, so in a non-neoplastic thymus, where thymopoiesis takes place, where T cells are in development and in maturation, it is also known that there is a high level of expression of PD-1, PD-L1, as you can see here, or CTLA4 marker. And some paper report that even in thymic tumor patients, there is a thymopoiesis-like phenomenon still going on. That is why the detection of the PD-1 and PD-L1 biomarker are probably not specific to tumoral thymic epithelial cells or to cytotoxic antitumoral T cells, but they can also be due to the presence of this thymopoiesis-like phenomenon in thymic epithelial cells, in TET patients. A second biomarker of response to immune checkpoint inhibitors is the level of the tumor mutational burden. To have a high tumor mutational burden is supposed to be predictive of better response to immune checkpoint inhibitors. However, as you can see here on the right, in TET, the tumor mutational burden is one of the lowest we can find in different tumor types. And moreover, immune checkpoint inhibitors are meant to activate CD8 cytotoxic T cells to attack tumoral cells. And there is no clear description of such a population of specific antitumoral CD8 cytotoxic T cells in TET patients. So we have arguments for efficiency of immune checkpoint inhibitors in TETs, but these arguments are not the most robust one we can have. But concretely, which data do we have about immune checkpoint inhibitors in thymic epithelial tumor patients? So you can see here some older trials. that tested anti-PD-1, pembrolizumab or nivolumab, or anti-PD-L1, avelumab, in either thymic carcinoma or thymoma. And it was at metastatic stage in advanced line of treatments after a doublet of platinum for the first line. And what is interesting concerning the efficiency, we can see that 20% of the patients in the first trial met a partial response. At least 19% of thymic carcinoma had a partial response as well in the second trial. In the third trial for thymoma patient, we have 29% of partial response, and in the last trial, more than 70% of stable disease. So clearly, some patients benefit from immune checkpoint inhibitors. However, if we look at the safety part of this table, we can see that at least 15% of patients present severe autoimmune-related adverse events in the first trial. In the second trial, in thymoma from Shaw et al., more than 70% of the patients presented severe autoimmune-related adverse events, more than 60% in the third trial, and 13% in the last trial. So yes, there is an efficiency of immune checkpoint inhibitors in TET patients. In subgroups, in a subgroup of patients, we can say close to 30% of patients with TET benefit from immune checkpoint inhibitors, but this subgroup is not clearly defined yet. And however, the fact that there is an efficiency of immune checkpoint inhibitors means that the human response has been enhanced and that there exists an antitumoral subset of T cells or of immune cells that contribute to this efficiency. However, the enhancement of this immune system also leads to numerous autoimmune-related adverse events that can be severe. And this is really something we should have remain aware of, and this is a concern. I like this figure because it summarizes the different autoimmune-related adverse events we can meet in our patients with TET under immune checkpoint inhibitors. So we can find in the peripheral blood of our patients antibodies that can lead to myasthenia gravis or myositis, that can lead to diabetes, pneumonitis, adrenal insufficiency, some dermatological dermatitis, thyroid dysregulation, colitis, blood system anemia, hepatitis, and myocarditis. Of course, some of them can be life-threatening. What I wanted to say is that there does not exist today biomarkers to predict that a patient will develop an autoimmune-related adverse event under immune checkpoint inhibitors. So we have to remain careful and to systematically look for these immune-related adverse events for our patients under immune checkpoint inhibitors. But what are the recent and ongoing clinical trials with immunotherapies in TET? So some trials, I wanted to present you these two trials, have been tested with vaccination. The first trial used the cancer testis antigen epitope, and the second trial, the WT1 epitope. They were phase 1 clinical trials from America or Japan. And the results were not very conclusive, but it is still interesting to see that some trials are testing vaccination therapy in thymic epithelial tumors. We still need one more specific tumoral antigen for TET that will maybe help this immunotherapy strategy in our patients. Then I will discuss mostly about immune checkpoint inhibitors that are in development or tested in different clinical trials. So we can see that immune checkpoint inhibitors are tested at the different stages of the disease. For example, here we have a Chinese trial at the early stage of the disease before surgery in the neoadjuvant setting. And this ongoing trial tests toripalimab, so an anti-PD-1 drug associated with chemotherapy before surgery. It is a phase 2, so we don't have the result yet, but it is interesting that to see at different stage of the disease, immune checkpoint inhibitors are tested. Here it is the different immunotherapies tested in the first line treatments, when the first advanced line of treatments. The Chinese trial on the top is in combination with radiotherapy and drug that boost the interferon response to boost inflammation and to recruit immune cells on the place of the radiation. So it is an interesting combination for first-line advanced thymic epithelial tumors. It is ongoing. We can also see in monotherapy the pembrolizumab that is tested in first line in unresectable thymoma and different thymic tumors, phase 2 from America. And we also have a combination of different drugs in first line. It is an ongoing Japanese trial, Artemis, that tested pembrolizumab, so the anti-PD-1, in association with cisplatin, Taxol, and lenvatinib that we just had a presentation before by my colleague. What I wanted to also tell is that I went to all these different clinical trials ongoing through the clinicaltrials.com the website. And I looked also to the different exclusion criteria to be sure if there was something harmonized. And it is not easy to find harmonized exclusion criteria in trials with immune checkpoint inhibitors in TETs. I wrote here on the slide some of them. Usually when there is an active autoimmune disease, it is an exclusion criteria. If there is a past history of autoimmune disease, it can also be an exclusion criteria. If the patient is under corticosteroids or under treatment for an autoimmune disease for the last 7 days or 15 days, it can also be an exclusion criteria. But the exclusion criteria are not always harmonized between the different clinical trials I went through. I found it was an important point also to say, hopefully it will get more harmonized later on. And then my last slide about the ongoing clinical trials at the advanced stage. So it is after the first line at metastatic stage. We have some immune checkpoint inhibitors in monotherapy or in combination. So in monotherapy, we have this KN046 drug, which is a bispecific antibody targeting PD-L1 and CTLA-4 at the same time. It is an ongoing trial. It is for thymic carcinoma. Second trial against in-thymic carcinoma, we have some results with atezolizumab, Tecentriq, this anti-PD-L1. This is a new result I found, and the overall response rate was 14%. Still, we still have the incidence of autoimmune adverse events in 30% of the patient. The third trial is a French trial, Nivotim, which tested nivolumab, anti-PD-1, in patients with thymic carcinoma or B3 thymoma. It was restricted to the B3 subtype. And this trial did not meet its primary endpoints, but still there was a nice signal with a progression-free survival rate at 6 months of 35%. 12% of overall response rate, but again, more than 50% of grade 3 or 4 adverse events. There is a second cohort in this Nivotim trial. This time it is a combination of nivolumab and ipilimumab, and the results will be presented at the ASCO 2025. And bintrafusp alpha in thymoma and thymic carcinoma is a protein that targets PD-L1 and TGF-beta. It is an American trial. Then what about the combination trial with immune checkpoint inhibitors? Sometimes it is just for thymic carcinoma, sometimes it is for thymoma and thymic carcinoma. Tislelizumab anti-PD-1 in combination with anlotinib, anti-EGFR, we discussed in the previous presentation. It is an ongoing Chinese trial. This trial with pembrolizumab and chemotherapy in advanced setting. Interesting, epacadostat, an IDO inhibitor. It stimulates immune cell growth. So pembrolizumab is associated with another drug to stimulate immune cell growth and also to activate potential antitumoral T cells, and ongoing trial. And then the last trial I wanted to discuss with you is a PECATI trial. So again, a French trial, this time only focusing on thymic carcinoma patients, but with nice results. It is still a phase 2 trial. As you can see, I only have phase 1 or phase 2 trial here. And this PECATI trial is terminated, and there is an overall response rate of 21%, and it met its primary endpoint. The 5 months progression-free survival rate was close to 90%. So it is a very encouraging result for pembrolizumab in thymic carcinoma patient, pembrolizumab and lenvatinib in thymic carcinoma. What we can see is that also in the different trials I presented to you, there seem to be, again, 15, like a subgroup of patients among thymic carcinoma patients and among thymoma patients that have good response to immune checkpoint inhibitors in monotherapy or combinations. But there is still a high level of autoimmune-related adverse events. And this level of autoimmune-related adverse events also seems to be higher in thymoma than in thymic carcinoma. To conclude, what we can say is that we don't know about immunotherapies, and mainly immune checkpoint inhibitors such as anti-PD-1 and PD-L1, which are the most frequent drug tested so far, are today tested in clinical trials at different stages of the disease. We can see some patients that have an objective response. So there is some patients that benefit from immune checkpoint inhibitors. However, a large amount of them, many patients, will develop autoimmune adverse events. And I think challenges for the future is that we need to identify which patient will benefit the most from immune checkpoint inhibitors and with less toxicity. And hopefully, we will be able one day to have some biomarkers to predict that a severe an autoimmune adverse events can arise. And we need for that ancillary studies, and we need to include our patients in different clinical trials with immune checkpoint inhibitors, because there is an interesting level of response, but we need to monitor them carefully to better understand why there is a response and why there is a severe autoimmune adverse event.